Hello everyone, this is a presentation discussing type 1 diabetes as it relates to the nursing practice. The presentation has been created by myself, Jacob Robertson, Tanya Trin, and Madison Carrick. So, type 1 diabetes is a chronic disease. In people with type 1 diabetes, cells in the pancreas that make insulin are destroyed so that the body is unable to make insulin. Insulin is a hormone that helps your body's cell use glucose for energy. Your body gets glucose from the food you eat. Insulin allows the glucose to pass from your body into your body's cells. When the cells have enough, your liver and muscle tissues store the extra glucose in the form of glycogen. It's broken down into blood sugar and released when you need energy between meals, during exercise, or while you sleep. With type 1 diabetes, your body is unable to process glucose due to the lack of insulin. Glucose from your food can't make it into the cell. This leaves too much glucose circulating in your blood. High blood sugar occurs, and this leads to short and long-term problems. Type 1 diabetes is thought to be caused by an autoimmune reaction in some people. The body attacks itself by mistake, essentially. This reaction destroys the cells in the pancreas that make insulin, called beta cells. This process can go on for months or years before any symptoms appear. So, some standard signs of that will lead to the person's first doctor appointment are frequent urination. Often this can occur like as bedwetting in children, where bedwetting didn't occur before, extreme hunger, unintended weight loss, irritability, and other mood changes, fatigue, weakness, and blurred vision. In people with type 1 diabetes, the onset of symptoms can be very sudden, while like type 2 diabetes, they tend to be more gradual, and sometimes there are no signs at all. Symptoms sometimes occur after a viral illness. In some cases, a person may reach the point of diabetic ketoacidosis before a type 1 diagnosis is made. DKA, diabetic ketoacidosis, occurs when blood glucose is dangerously high and the body can't get enough nutrients into the cell because of the absence of insulin. The body then breaks down muscle and fat for energy, causing an accumulation of ketones in the blood and urine. Symptoms of DKA include a fruity odor on the breath, heavy taxed breathing, and vomiting. If left untreated, DKA can result in stupor, unconsciousness, and eventually death. Some people with type 1 have a honeymoon period. So this happens a lot in kids. They have a brief remission of symptoms while the pancreas is still secreting some insulin. The honeymoon phase usually occurs after someone has started taking insulin. A honeymoon can last as little as a week or up to a year. But it's important to know the absence of symptoms doesn't mean that the type 1 diabetes has gone away. The pancreas will eventually be unable to secrete insulin, and if untreated, the symptoms will return. So in children, we're looking out for the 3 Ps, which we all know: polydipsia, increase of thirst, polyuria, frequent urination, polyphagia, rise in appetite, and the biggest one is a lot of bedwetting will happen too. Healthcare professionals most often most often they'll see children present because of these symptoms, and then that will relate to a diagnosis of diabetes. Also, extreme fatigue can occur after exercise, and just signs of hypoglycemia and hyperglycemia during that honeymoon phase for children too. Thank you.
Diagnosis. Healthcare professionals most often use the fasting plasma glucose (FPG) test or the A1C test to diagnose diabetes. In some cases, they may use a random plasma glucose (RPG) test or glycated hemoglobin test. For fasting plasma glucose, a blood sample will be taken after an overnight fast. A fasting blood sugar level less than 100 mg per deciliter is normal. A fasting blood sugar level from 100 to 125 mg per deciliter is considered pre-diabetes. If it's 126 mg per deciliter or higher on 2 separate tests, diabetes is diagnosed. A1C or glycated hemoglobin is a form of hemoglobin that is chemically linked to a sugar. Most monosaccharides include glucose, galactose, and fructose, spontaneously bond with hemoglobin when present in the bloodstream of humans. It can identify pre-diabetes, can be used to diagnose diabetes, and is used to monitor how well your diabetes treatment is working over time. It is also a critical step in forming your game plan to manage diabetes with your care team. A1C test results are reported as a percentage. The higher the percent, the higher your blood sugar levels over the past 2 or 3 months. The higher your blood sugar levels, the more hemoglobin you'll have with sugar attached. An A1C level of 6.5% or higher on 2 separate tests indicates diabetes. In 2018, the American Diabetes Association, ADA, reiterated its long-held recommendation that children with type 1 diabetes should aim to have an A1C of less than 7.5% target. A1C goal may vary depending on your age and various other factors. The American Diabetes Association generally recommends that A1C levels be below 7%, which translates to an estimated average glucose of 154 milligrams per deciliter. Random plasma glucose, RPG test, also known as CBG or blood sugar, it measures the sugar levels in your blood at the moment in time. An RPG results that over 200 milligrams per deciliter is indicative of diabetes, especially if you're having symptoms of diabetes such as excess thirst, hunger, or urination. Patients with diabetes ketoacidosis will have blood sugar levels above 350 milligrams per deciliter. Treatment options. The primary and only solely approved treatment for type 1 diabetes is regular insulin use. Rapid-acting insulin begins to work about 15 minutes after injection, peaks in about 1 or 2 hours after injection, and lasts between 2 to 4 hours. Types include insulin aspart, insulin glutazine, and insulin lispro. Regular or short-acting insulin usually reaches the bloodstream within 30 minutes after injection, peaks anywhere from 2 to 3 hours after injection, and is effective for approximately 3 to 6 hours. An example is human regular, which includes Humulin R and Novolin R. Intermediate acting insulin generally reaches the bloodstream about 2 to 4 hours after injection, peaks for 4 to 12 hours later, and is effective for about 12 to 18 hours. An example is NPH, which includes Humulin N, Novolin N, and Relion. Long-acting insulin reaches the bloodstream several hours after injection and tends to lower glucose levels up to 24 hours. Types include Degludec, Detamir, and Glargine. Ultra-long-acting reaches the bloodstream in 6 hours, does not peak, and lasts about 36 hours or longer. An example includes Glargine U300. To administer insulin, patients with type 1 diabetes may use a pump or self-administer insulin. Injections are cheaper and take less training to use than insulin pumps. A patient will have to test blood sugar levels before every injection. Conclusions and prevalence among young patients with type 1 diabetes: insulin pump therapy compared with insulin injection therapy was associated with lower risk of hypoglycemia and diabetic ketoacidosis, and with better glycemic control during most recent year of therapy. There are a variety of ways to monitor glucose, such as under-the-skin implant, finger-stick tests, and soon-to-be approved non-invasive testing methods. Diet and physical activity are critically important in the management of ABCs, A1C, blood pressure, and cholesterol of type 1 diabetes. To effectively manage glycated hemoglobin A1C and achieve stable blood sugar control, it is important to understand how to balance food intake, physical activity, and insulin. Eating a consistent amount of food every day and taking medication as directed can greatly improve blood sugar levels control and decrease the risk of diabetes-related complications such as coronary artery disease, kidney disease, and nerve damage. In addition, these measures impact weight control. A dietitian can help to create a food plan that is tailored to your medical needs, lifestyle, and personal preferences. Consistently eating at the same time every day is important for some people, especially those who take the same amount of insulin at the same time every day, called fixed regimen. If a meal is skipped or delayed, you are at risk for developing low blood glucose. People who use intensive insulin therapy, those on insulin pump or multiple daily insulin injections, have more flexibility around meal timing. With these regimens, skipping or delaying a meal does not usually increase the risk of low blood sugar. Carbohydrates are the main energy source in diet and include starches, vegetables, fruits, dairy products, and sugars. Most meats and fats do not contain any carbohydrates. Carbohydrates have a direct impact on blood sugar levels, whereas proteins and fat have little impact. Eating a consistent amount of carbohydrates at each meal can help to control blood sugar levels, especially if you're taking the same amount of insulin at the same time every day. Fixed regimen. People who take insulin should check their blood sugar levels before and after exercising. If exercise is vigorous and prolonged, more than 30 minutes, check your blood sugar every 15 minutes. If the exercise regimen is new, it may be used again. Frequent monitoring can help to get a sense of what effect exercise has on your blood sugar level.
Okay, now we're going to go ahead and talk about some nursing interventions that come along with type 1 diabetes. One of the first interventions is to ensure adequate and appropriate nutrition. A patient with type 1 diabetes needs a sound nutritional program that provides adequate nutrition for normal growth while also maintaining blood glucose at near normal levels. A diet for diabetics is usually prescribed as 45% carbohydrates, such as strawberries and blueberries or brown rice, 15 to 20% of protein, such as beans and lentils, 20 to 35% of unsaturated fats, such as avocados. The food plan should be well balanced with foods that take into consideration the child's food preferences, cultural customs, and lifestyles. If a particular meal is going to be late, the child should have a complex carbohydrate and protein snack. Nursing intervention is going to be that prevention of skin breakdown. We're going to want to educate the caregiver as well as the patient to inspect their skin daily and promptly treat even small breaks in the skin, as diabetics are more prone to infections. We're going to teach the patient to bathe daily and also make sure that they're drying their skin thoroughly after they're bathing, especially in places where skin touches skin, such as in the groin, the armpit, and between the toes. As well as checking for other skin folds that they may have, such as in the abdomen. We're also going to want to emphasize a good foot care, so taking their shoes off, taking their socks off, and taking a look at those toes every single day. In addition, we're also going to prevent any infection. Diabetic patients may be more susceptible to urinary tract infections as well as upper respiratory infections. We're going to want to teach the client and their caregivers to be alert for signs of urinary tract infection as well as signs and symptoms of an upper respiratory tract infection, and to report these to their provider. We're going to go ahead and educate that insulin should never be skipped during illnesses and fluids need to be increased during illnesses. As nurses, if this patient were hospitalized, we might be monitoring any wounds that they might have or any open cuts or scrapes to look for signs or symptoms of any infection. We're also going to be just, checking, taking a look at that skin daily to see if there are any abrasions or other wounds that might cause infection. We can also be monitoring for signs and symptoms of infection by monitoring white blood cell counts. Nursing intervention for this condition, type 1 diabetes, is going to be regulation of glucose levels. The patient's blood glucose levels must be monitored and maintained within normal limits. We're going to determine the blood glucose level at least twice a day, or as the provider has ordered. We're also going to monitor that blood glucose before and after meals, as well as before and after any activity. We're going to have interventions on hand for hypoglycemia, which might include a high-carb, high-protein snack, as well as maybe 4 ounces of juice. In severe hypoglycemia, we'd want to have glucagon intramuscular on hand, as well as D50W for intravenous fluid replacement, as well as glucose. For hyperglycemia, some interventions that we want to have on hand include insulin preparations, and be prepared to administer it as per the sliding scale. We're going to want to educate the patient and the caregiver on the signs and symptoms of hypoglycemia and hyperglycemia. Our final nursing intervention is going to be providing education to the client and their caregivers, which we will discuss on the next slide. So as we discussed previously, we're definitely going to provide education to the patient and their caregivers regarding these signs and symptoms of hyperglycemia as well as hypoglycemia, and when to contact their provider. We're also going to want to educate the patient on how to use their glucometer and how to read the glucometer, and they should know the ranges for hypoglycemia, hyperglycemia, and their goal ranges. We're going to want to educate the client to how to draw up their insulin, how to prepare their insulin, and how to inject their insulin using the proper sub-Q technique. We're also going to want to educate them to alternate sites to decrease that chance of lipohypertrophy. Also going to educate them on the onset, peak, and duration of their type of insulin that they've been prescribed. We're going to go ahead and teach them to have consistent meals. We're eating roughly the same things at roughly the same time, and that will help regulate glucose levels. We're also going to teach them to avoid exercise at peak insulin times, as well as exercising 30 minutes to an hour after eating to avoid hypoglycemia.